Hello friends, this is a case of laparoscopic myomectomy. This is a large myoma. These are the anterior superior iliac spine. This is the GP sternum. These are the costal margin. So, this patient has a multiple large myoma and we will perform the laparoscopic myomectomy. There is a one large myoma which is reaching up to the umbilicus here and two intramural deep myomas. So, larger one has approximately size of 15 centimeter and two a smaller intramural deep myoma, one is 6 centimeter and another is 5 centimeter. So, we will perform the laparoscopic myomectomy, and in those situations you have to enter with the Palmer's point. So, we have to be careful that this is the Palmer point, mid clavicular, just below the costal margin we will put the port, and first we will put the 5 and then we will put the under vision of 5 telescope, we will put supraumbilical port, that is for your optics, but initially we will use 5 and later this 5 use it for the instrument and the telescope will be transferred to the supraumbilical port. So, this is the idea. We will take two ipsilateral and one contralateral port. So, just start. This is the mid clavicular line just below the costal margin and this will be our telescope, that is supraumbilical, approximately 6 to 8 centimeter above the upper border of the myoma fundus. But directly if you will go there, there may be injury to the bowel or we may find some adhesion, and this will be the third port, and distance between the second and third port, especially in cases of ipsilateral port, we will keep it approximately 8 to 10 centimeter. So, this is the costal margin and we will start the Palmer point entry. So, this is the midline where you will put the telescope later, but initially to enter in the Palmer point there is no necessity of using the 10 port. So, we will use just the a small nick and we will use 5 port there. So, this is the stab wound given and the varus needle is introduced to the Palmer's point. Here you will get the 3 click sound because of the aponeurosis of external oblique, aponeurosis of the and then internal oblique and then peritoneum. So, it is introduced. Now, we will take a syringe and we will do irrigation, suction, hanging drop test. So, this is irrigation test, suction test and hanging drop test, and we can see this hanging drop is going in. After that, we will attach the tubing of the insufflator and the insufflation will started. Preset pressure we are keeping to 15. We can see liver dullness is getting obliterated and the homogeneous distension started. So, preset pressure is kept here at 15 and slowly actual pressure will reach to the preset pressure, and once the actual pressure and preset pressure is equal, then we will remove the varus needle. So, flow rate is here, it is the 1 liter per minute, minimum amount of gas required is 1.5 liter and maximum is 6 liter, and we can see now homogeneous distension is already done, and now we will remove the varus needle and then enlarge the incision to 5 and then the 5 port will be introduced, so that we can introduce one 5 telescope and then under vision we can put the supraumbilical optical port, that is 10 and later this 5 you will use for the right hand instrument. So, now this 5 telescope is introduced and then we will take care that at least we should be 24 centimeter away from the base of the myoma. So, this is the telescope you can use to measure, and this will be 2/3 and this should be here, and so port will be introduced according to the size of the myoma, and base of myoma should be our target. So, this is the 10 mm port, and now it is very safe. It will not injure any organ because it is under vision of the 5 mm telescope. So, now it is introduced. It is safe because it is under vision. If you are going only 5 centimeter above the umbilicus, then you can directly go, otherwise better to go with the Palmer's point and then go with the telescope, so that accidentally you cannot damage the liver or the duodenum or transverse colon. Now, the patient head is going down, we will put 30-degree head down, and then under vision we will put the second port. Once we have head down, then together we should do table also down, because handle of the instrument should be at the level of elbow when you perform comfortable suturing and knotting. So, this is important. This is a large myoma. Here is the anterior superior iliac spine, and approximately 8 to 10 centimeter below we will put the another port, palm width you can use. So, this will be the second port. Later we will put one contralateral port also, so that assistant can help, but most of the myomectomy you can do by 2 ipsilateral port. So, now telescope is inside, and under vision we will put another 5 mm port. So, we will do initial diagnostic laparoscopy to check. Here we can see this is a large, and this one is mostly subserous. So, this is a large fibroid, uterus is down there, ovary and tube, left tube is visible, sigmoid colon is visible. So, you can do the initial assessment of the anatomy, this is very important. And we are lifting the uterus, this is the another fibroid is posterior wall, and these are the, this is anterior wall, and these are the 2 posterior wall fibroid which is completely pushing the rectum down, and this is pressing over the left ureter also, as well as right ureter, and this is the uterus, tube is also visible, ovary is visible. So, we should be careful that tube and ovary should not be injured. And this is the ovary of the left side, this is the right ureter you can see, which is crossing the external iliac vessel. This is aorta, here is the aorta, and this is the common iliac vessel, and then external iliac. Right side of ureter is crossing external iliac vessel, and left side of ureter crosses common iliac vessel. So, this is right side of ureter. You can clearly see the peristalsis also, and bifurcation below will be the internal iliac. So, this is the ureter, and just below the ureter what you are seeing is internal iliac. This is external iliac vein, here it is going, and this is external iliac artery, and vein is medial, and this is internal iliac which you can see pulsating, and this is ureter. So, ureter is crossing external iliac. Left side, this is the sigmoid colon, and this is the left ureter which is the more medial, and this is the IP ligament. Once you will lift the IP ligament and put the telescope inside, then you can clearly see the left ureter which is crossing, and below is the internal iliac. This is external iliac of the left side, this is IP ligament, and uterus is below, and below that uterus there is one more large fibroid. So, these are the initial assessment of the anatomy, and good thing about the thing is that there is no any endometriosis, and there is no any dense adhesion. So, we will start now, and we will inject the vasopressin. We can see it is very vascular. However, it is subserous, this one, but very large and vascular. This is the uterus, and here is the bladder. This is UV fold, and This is the medial umbilical ligament which is going, and here is the deep ring, and this is the iliac vessel. So, this is the anatomy, and this is the deep ring here, and round ligament is entering into the deep ring of right side, and this is the medial umbilical ligament of left side which is visible. So, initially we should take little time to nicely see the anatomy and do the visual interpretation of the anatomy. That will be in your memory, so that you can do predictive anatomy. And now we are injecting the vasopressin, and we should be careful that vasopressin should not enter into the myoma. It should be entered in the above the capsule, so that it should do the blebbing. We can see blebbing is started, and then it is doing hydrodissection. So, that is important. Accidentally you should not put the vasopressin inside the myoma tissue, otherwise there will be no advantage. You can see hydrodissection and blanching is started, that is called marble white appearance, and you have to press the syringe of the vasopressin under a lot of pressure, so that it can do hydrodissection. And now we will start incision here. So, this is the landmark of the incision which we are going to start. It should be parallel to the harmonic. Oblique incision we will give here, so that suturing will be easy, and this is our landmark of doing the suturing. Incision should be at least 2/3 of the size of the myoma. Bigger is the myoma, then incision should be enough, so that you can remove. So, we can see it is very vascular, but cutting with the harmonic has the advantage that it will make, because once it break hydrogen bond, and due to the shock wave which harmonic produce, will create its own plane of dissection. So, slowly our incision is continuing, and left hand grasper is supporting the uterus, and then we will continue the further incision. So, the incision is complete. After that, you should try to split, so that capsule will pop out. And then by gentle pushing and pulling technique, you can try to enucleate the myoma. Because this is subserous myoma, so if you have a good plane, it will come out easily. If little oozing happens, immediately we should not try to do the suction, better to remove it, and then clearly you can do the suction. This, as we have changed again a traumatic grasper to the traumatic grasper. so that once you hold the serosa, it will not slip. So, this is a traumatic grasper on the left side, and slowly it is stripping the serosal layer to enucleate the first large subserous myoma. So, it is reaching to the base, and some of this part of the myoma has intramural component. So, we have to use little energy so that bleeding will not happen, and it is better to cut with the vibration of the harmonic in mechanical energy in these areas. So, this myoma is separated. Now, before going to the posterior wall myoma, we can see this is a tube either side, and below is the posterior wall. So, better is to suture this in two layer. We will suture the muscle layer and then the serosa layer. So, better is to suture because bleeding will stop, and first you will repair it, then we will proceed for the another myomas. So, here we are using barb suture, that is V-lock, and as you know V-lock has a loop there on the tail end. So, you can pass the suture and you can lock it. It is a unidirectional barb suture. So, this loop we are making a big loop. So, loop within loop, and then it will be easy to lock it. This is locked. So, this muscle layer suturing will continue. Advantage of suturing the muscle here is that you will not have bleeding, and it will give a strength to the muscle, so that uterus will not rupture in the subsequent pregnancy, and there will be no dead space. So, it is always better recommended to, even if it is subserous, and if it is has little intramural extension, then two layer is good. So, now we will return back, and some of the remaining obliteration of the dead space will be carried by returning back. So now we will exit over the healthy serosa, and then again the serous layer will be taken by returning back. You may use the baseball suturing, but here we will use the simple suturing. And this is a serous layer suturing is started. From the corner you should include. We should must come out from the serosa so that margin will get inverted. So inversion of the serosa will give pressure also, bleeding is stop, and there will be no raw area outside. So it should be carefully sutured and the margin should be inverted. In open surgery, we cut out the excess of serosa, but here you should not cut because it's useful to obliterate the dead space and there will be no adhesion. So it is inverted inside. We should be careful that suture should fall over the inversion so that it give pressure. We can see as it is sutured, now the bleeding is stopped itself due to the pressure effect. And margin is inverted. So because this is barb suture, so we will exit in the deep muscular layer so that you don't need to terminate and you can directly cut the suture and you can exit in the healthy area. Below is the tube, so you should be careful that any bite should not be taken on the tube. And now it can be terminated. Little suture is there, this margin also we will invert it. You can use suture as a retractor, and the suction you can do to clean the area. Now this is another myoma which is down in the posterior wall, and that also we have to remove. This one is also large myoma, we can see this is posterior wall, and it is just pressing the rectum, and it is completely intramural, and another one is lateral wall. So we have to start giving incision of this part of the myoma. So we have to re-inject the vasopressin in this area. So suction is performed, all the blood was sucked out, and this is the re-injection of the vasopressin. This is the lateral one, and this is injecting, and that will do its own hydrodissection. Problem is it is below the ovary and tube, so we have to utmost importance should be given that it should not damage the tube and ovary. So these are the two large myoma which we will remove one by one. So and ovary should be not damaged. So we will give little circumferential incision here in the left one, left posterior wall, and one is the right lateral wall. This is a good plane. This is the capsule of the myoma. This is posterolateral. It is posterior as well as lateral extension. So here we have to use myoma screw applying on the base and giving anterior traction, and with the pulling and pushing technique slowly we should remove this myoma as well. This is the muscle layer of the posterior wall of the uterus, which is extending. it is going more deeper, so incision has to be enlarged. Now it is coming out. In myoma screw, we will rearrange to the base so that traction by the myoma screw can be optimized. So here we have to be careful about the bleeding. So we should not suddenly avulge. We should cut those tissue better by harmonic rather than avulging it. So this is also not a small, I think it is around 10 centimeter this also. MRI has not shown it that much big, but it is too big. Now this is the third one, so we will extend the same incision. Myoma screw is reapplied on this, and now it will be easy to separate. because obstruction will be optimized. As I told you, incision should be 2/3 of the size of the myoma. So, little bit incision also has to be increased, and this is now coming. This is also out. Now we have to do a lot of suturing. So, we can see cavity is not open, that is good news. And now we can start suturing. So, this is again muscle layer, deep bite is started with the V-lock suture. Bleeding, you should not do unnecessary coagulation. As soon as you will approximate the muscle tightly, the bleeding will automatically stop. However, if it is an active bleeder, you are seeing the bleeder, then we should use ligation to coagulate. But these are the oozing from the muscle, so better is to not spend the time and keep on taking a deep bite and suture. So, this is the second layer now. So, we will also suture in 3 layers to obliterate and give the enough strength to the uterus. If you will not do proper suturing and anyhow just coagulated and approximate the serosa, then always we have a chance that uterus will be weak and there may be rupture of uterus in subsequent pregnancy. So, proper suturing is always necessary in the cases of laparoscopic myomectomy. And another challenge is that tube and ovary should also not be injured. So, this corner is sutured so that bleeding will stop. And now we started the serous layer. These are the muscle layer. So, muscle layer also we will continue further. This is the second muscle layer, so that there should not be any dead space. And then we will return back to the serous layer again. Again exit to the healthy serosa and then approximate the serous layer again. So, margin is getting inverted now, and this is the final serous layer to approximate the raw area. What this bulge you are saying, within few months, once uterus will get reformed and the shape will become okay. Right now this shape is looking because of this incision. When once uterus will remodulate and it will become normal in the shape. So, now we will cut it here. Needle was too small. So, we have to put the another suture to continue further. This is again another barb suture. You can see through the smaller loop, one bigger loop is formed. In the meantime, we can do little suction. Now there is no any bleeding. These are the collected blood. This is cul-de-sac that is cleared. There is no adhesion with the rectum. Everything looks fine. Rectum is below and cul-de-sac is good. Everything is fine. Ureter, either ureter is also visible and no bleeding. Better to keep this fibroid on the right iliac fossa at one place so that it should not get dropped here and there. Now again we will start the third layer suturing. Suture itself will act as a retractor. So there is no role of the assistant, much role of the assistant in laparoscopic myomectomy. However, we have put one contralateral port, but assistant was rarely used because you need to have a ambidextrity. You both the hands should work in a one coordination. So, this patient both the tubes are very good. We have never touched it also. Ovaries are fine. So, I think not there should never be any problem of infertility and she should conceive nicely. Uterus also is quite nicely in multiple layer repaired. So, there will be absolutely no problem. Shape what you are seeing this bulge is due to the suturing. Once the suture will absorb, the tissue will get completely reformed. And after few months, it will become a shape of a normal uterus. So, we have more suture left, then why not to go return back and take the advantage of remaining suture to strengthen the uterus little more. So, we are returning back and you may say it is fourth layer of suturing. So, everything is fine. Bleeding is examining. Is there any bleeding? Just to check. So, now we will do the suction irrigation, waiting for a little bit, see that is there any bleeding happening, and there is no bleeding. Harmonic is used to cut the suture and it is dry, there is no bleeding. Now we will start morselation. Morselation is a time taking job. As far as the morselating in the Morsafe endo bag is required, that this large one is not possible. Morsafe has its own capacity to put up to 10 or 12 centimeter. So, here you have to do morselation. This is the smallest one and there are two large. So, I will not show you the entire morselation process because morselation is a time taking process. You should must be careful that during morselation, here it is a starch morselator, it is a very sharp knife. So, it does not grind the tissue, but you should take care that any piece of the tissue should not be left inside. If some of the broken part is there with the stone holding forceps, you should take it out carefully. But the starch morselator blade is very fine, so it does not grind the tissue. So, this is the second one and then the last one. So, morselator I will not show you completely, and after proper morselation, once then we will do the proper suction irrigation and then port closure is must. If you will not do the port closure, there will be hernia chances, because the morslator ports are 12 or 15 Two type of cannulas are there, blades are, according to that we have to use. So, morselation has a rule that morslator should not go to morselate the tissue. Tissue should come inside the morslator to get morselated. So, this is the second one. Third one is very large. So, multiple large myomas are very difficult to put all in the endo bag to take it out, and those patients are very young patient, unmarried patient. So, their age is very less, sarcomatous chances are extremely less. But fragmented part should be carefully taken, otherwise satellite myoma can form. So, this care should be taken. So, thank you very much for watching this video. This was little difficult case. However, we have removed up to 30 centimeter fibroid. You can see this is at the end of the surgery. This is the wound. You can see these are the ports. So, thank you very much.